Value of imaging. Welcome. In this lecture, I will introduce the key concepts that form the conceptual framework for valuing imaging. This will be a qualitative discussion. At some later stage, I will explain the methodologies behind these key concepts. How do we value any medical technology? Let's ask ourselves a very fundamental question. What is the purpose of medical intervention? It is to make people live longer and live better. One metric which captures that, albeit imperfectly, is quality adjusted life year, QALY or QALYs. So how does imaging fit into this? Let's say we're measuring the value of CT for pulmonary embolism using QALYs as our metric. How do we go about doing that? We take a cohort of patients, hypothetically speaking, all with the same index of suspicion for PE, which is to say, some have PE, most don't, or many don't. We divide them into three groups. In the first group, we treat everybody with anticoagulation. This is the treat all group. In the second group, we treat nobody with anticoagulation. This is the treat none group. And in the third group, we image everybody and treat only those who are positive for pulmonary embolism. Okay, so bear that in mind. Bear those three groups in mind. Now, for imaging for PE, for CT for PE, to have value using QALYs as a metric, the image and treat group must yield higher QALYs than the treat all or the treat none. This is to say that there is value in discerning those who actually have PE, but it goes beyond that. Imaging has value for PE if there is value in treating PE, if there is some purpose to that discernment at all. Imaging also has value when it changes our belief. Let us say that there is a certain belief of the existence of aortic dissection in a patient who complains of chest pain. Let's call that degree of belief PD0 before we image. If the degree of belief after imaging, PD1, is different to PD0, imaging has value. That means to say that imaging must either increase or decrease our belief that aortic dissection exists for it to have value. In a similar vein, imaging has value when it reduces uncertainty. Okay, that's a very nebulous phrase. What do I mean by reducing uncertainty? Let us say that somebody who is 45 years old has abdominal pain and weight loss of 3-month duration. There is a certain bandwidth of possibilities, differential diagnosis, things the person might have. Imaging has value when it contracts that differential diagnosis, when it reduces the bandwidth of possibilities, when it reduces uncertainty. The fourth area where imaging has value, or that can be used to value imaging, is avoidance of worst-case scenarios. The quality and safety movement call these never events. One is one too many. An example, which I'm sure many of you encountered in your practice, is the misplacement of enteric tubes in the bronchial tree. In order to achieve a zero occurrence of that catastrophic misplacement, or a misplacement that could have catastrophic results, there's a certain amount of imaging that is contingent upon that. So imaging has value when it leads in a global population scale to achieving zero occurrence of a catastrophic event. Okay, it's time now to summarize these key citadels of the value of imaging. Imaging has value if it delivers more QALYs, more quality adjusted life years. This is the gold standard. This is what we should aspire to achieve, and this is what we should aspire to show. Imaging also has value when it changes our belief about the existence of a condition. Imaging has value when it reduces the uncertainty associated with the diagnosis and the differential diagnosis. And finally, imaging has value when it allows us to avoid never events. Of course, there is value to imaging beyond these four elements that I've mentioned, but I feel that these are the four most important citadels of imaging. You could even call these the four horsemen of the imaging value chain. Thank you.